Hi there. My name is Ahmed Hegazi and I'm an intensivist at London Health Sciences Centre. Today I'm going to be talking to you about volatile sedation in critical care. This is the first of a series of 4 videos where I'll be describing how we can use volatile sedation in the ICU. Let's start off with an introduction. So what are the options that are available to us in the ICU for analgesia and sedation? So for analgesia, we tend to use opioids quite a bit. NSAIDs, nonsteroidal anti-inflammatory drugs, are an option if there's no contraindication. Regional blocks can help with pain, and so can lidocaine infusions and ketamine infusions. But for the most part, we tend to gravitate to using opioids for pain control in the ICU in most cases. For sedation, on the other hand, our options include propofol, midazolam, dexmedetomidine, but I also want us to add to our armamentarium in the ICU the option of using inhalational agents or volatile agents for sedation as well. The classic indications of using volatiles in the ICU have been mainly in cases of really refractory status epilepticus, when all the other anti-seizure medications appear to be failing, and also in really refractory cases of asthma, when all other lines of treatment or bronchodilators are failing. But there are other patients where I'd like us to consider using volatile sedation in the ICU. There are patients that are difficult to sedate, like patients who are opioid dependent, or patients who have burns and require frequent dressing changes, or any patient that requires frequent sedation for procedures. These patients will tend to develop tolerance to opioids and benzodiazepines and tend to require escalating doses, and with each time it becomes more and more difficult to achieve adequate sedation. In these situations, I'd like us to consider using volatile agents. They tend to be very effective. The other thing I'd like us to consider is using volatile sedation for routine ICU sedation as well. And there are several reasons why we may want to use it for routine sedation. The first reason we may want to consider using volatile for routine sedation in the ICU is that volatiles tend to have rapid onset and rapid offset kinetics. Patients tend to go to sleep very quickly with volatiles and wake up very quickly as well. The second reason is they're not dependent on body metabolism for clearance. They're administered by inhalation and they're cleared by exhalation. So you breathe them in and you breathe them out. Also, the very little amount that does get metabolized from these agents does not give you any active metabolites. So unlike agents like midazolam, for example, where the IV formulation of midazolam does have active metabolites and you can take several days to wake up from a midazolam infusion, volatile agents, on the other hand, the very small amount that does get metabolized is completely inactive. The other advantage is the ability to monitor how much you are giving and what concentration is in the patient's body. With inhalational agents, you can actually monitor end-tidal concentrations, which will very closely approximate brain concentrations. You can't easily monitor how much you're giving with other agents, like for example propofol or opioids or midazolam. You usually run an IV infusion to clinical endpoints, but a lot of times these patients accumulate these medications in their body and their concentrations rapidly escalate. And when you stop these medications, it takes days for them to wake up. Whereas with inhalational agents, on the other hand, you have a real-time end-tidal monitor that tells you what concentration the brain is actually seeing in real time. They're also very predictable in their effects. You can very easily titrate how much you give, and they're, as I said, quick on, quick off. Lastly, they're very cost effective. Inhalational agents, when you compare them with IV agents, are much cheaper, and they'll likely always be available. So in a pandemic situation like we have right now, where you may have a shortage of IV sedative agents, inhalational agents, on the other hand, are very unlikely to run out. Volatile sedation, when compared to IV sedation, have been looked at in the ICU setting in post-op patients. This meta-analysis included studies mainly of post-op surgical patients and mainly post-op cardiac surgery patients, where you're usually sedating them for a few hours before you make sure that everything's okay for extubation. In these studies, they found that time to extubation was much shorter with volatile sedation when you compare it to midazolam, shorter by 292 minutes. When you compare IV sedation with propofol to volatile agents as well, it was found that volatile agents have a shorter time to extubation by about half an hour or 29 minutes. So volatile sedation wear off quicker than both midazolam and propofol. Well, how about patients that require longer-term sedation? Like, say, for example, acute respiratory distress patients, ARDS patients, that usually require sedation for maybe a week or two and sometimes more. There was one randomized controlled study that compared sevoflurane to midazolam in ARDS patients. It was a small study, a pilot study, that was really not powered to detect statistically significant differences in clinical outcomes. Nonetheless, there was quite the signal there. When you look at the total duration of mechanical ventilation, compare sevoflurane to midazolam, the sevoflurane arm was ventilated for 12.5 days in comparison to midazolam, where the patients were ventilated for 17 days. Look at the ICU stay as well, where the sevoflurane patients were in the ICU for 18 days versus the midazolam patients who were in the ICU for 23 days. As I said, these were not statistically significant, but there is biologic plausibility here that sevoflurane and inhalational agents in general are quicker to recover from. If indeed we find out that inhalational agents save time on the ventilator and result in quicker ICU discharge, then we may be actually saving a lot of ICU capacity, saving a lot of ventilator capacity, hence the SAVE ICU trial. When it comes to volatile sedation in the ICU in general, two options are available to us, and they are isoflurane and sevoflurane. Isoflurane, however, tends to be very cheap. Isoflurane and sevoflurane are administered by inhalation with an air-oxygen mixture, and the bottles of isoflurane and sevoflurane are stored at room temperature. So how would you administer volatile agents for sedation in the ICU? There's a few options available to us. The first option is using an anesthesia delivery unit, an anesthesia machine from the OR. These are very big machines, and it can be a challenge to move them to the ICU. They do need a level of comfort and expertise to run. Also, the ventilators themselves that are used in the operating room may not be as powerful as the ventilators that we use in the ICU. They're really ventilators that are built to ventilate patients in the short run for an operating time of hours, maybe a day, whereas in the ICU, we're typically ventilating ARDS patients for much longer than a day. The other option that's available to us is a mobile anesthesia delivery module, which is called a MADAM. This is basically a portable anesthesia vaporizer that both has vaporizing capability and monitoring capability as well. The last option that's available to us is an anesthesia conserving device, basically a disposable inline anesthetic vaporizer. This anesthetic conserving device is called the Anaconda. The Anaconda is basically a miniature vaporizer that not only vaporizes, but also conserves anesthetic agent. You hook up the ventilator circuit to one end of the Anaconda, and on the other end, you hook up the endotracheal tube. Then you run a volatile infusion into the Anaconda chamber, and on the other end of the Anaconda, there's also a gas sampling port where you can monitor how much the patient is breathing in and breathing out. In addition, the Anaconda is also a conserving device. It actually recycles more than 90% of volatile agent that the patient breathes out. So whatever volatile agent the patient actually expires is usually reflected back to the patient, and less than 10% goes back to the ventilator exhaust. The volatile anesthetic that you infuse into the Anaconda comes in syringes. These Anaconda syringes are specific color-coded propylene syringes that are non-interactive with the volatile agent. They also have a lure lock that is incompatible with standard IV sets. So this is an excellent safety feature where you really cannot be hooking the syringe to a central line. These syringes are mounted on regular syringe pumps, normal syringe pumps that you would use in the ICU, like the Braun syringe pumps or whatever type you have, and they infuse the volatile agent into the Anaconda chamber, which subsequently delivers the volatile, vaporizes it, and delivers it to the patient. The other equipment that also needs to be set up with inhalational sedation includes an end-tidal agent monitor. So with that, you will monitor how much inhalational sedation you are administering and how much the patient is breathing out. You will also need to set up a scavenging system, and we'll talk a little bit more about these in the Equipment Essentials section. There's a few contraindications to running volatile sedation using the Anaconda in the ICU. The first contraindication is having small tidal volumes. The reason is the Anaconda itself is a dead space chamber, and when you add on dead space to the circuit, the patient needs to be taking adequate tidal volumes in order to avoid rebreathing. One of the models of the Anaconda, which is the Anaconda S, has 50 mils of dead space. And so you need to have a patient who's breathing more than 200 mils of tidal volume in order to accommodate that dead space. For any patient who's breathing tidal volumes less than 200 mils, you run the risk of rebreathing. The second contraindication is when you are running inhaled prostacyclin or Flurane. Volatile sedation is incompatible with inhaled epoprostenol. Volatile sedation is compatible with all other inhaled medications, so you can run volatile sedation with nitric oxide, with nebulized Ventolin, with nebulized ipratropium. All the other medications are compatible with volatile sedation. The only inhaled medication that is incompatible is inhaled epoprostenol or inhaled Flurane. One lung ventilation tends to be a relative contraindication as well. Volatile sedation can obtund your hypoxic pulmonary vasoconstriction and give you a little bit of shunting and potentially worsen hypoxia. And so volatile sedation in the setting of one lung ventilation is a relative contraindication. Other relative contraindications include increased ICP. When you have a patient with uncontrolled increased intracranial pressure, volatile sedation can increase your cerebral blood flow and further increase your intracranial pressure. And so this is a relative contraindication. You should probably be running a propofol infusion if you have a patient with increased ICP. But if the ICP issue is controlled, say for example a patient went to the operating room and underwent decompressive craniectomy and now their ICP is back to normal, at that point in time you can go back to running a volatile sedative in the ICU. Last but not least, the absolute contraindication to giving volatile sedation is when the patient has a personal or a family history of malignant hyperthermia. That would certainly be an absolute contraindication to running volatile sedation. Thank you very much for listening in, and please join us for the next module where we will be describing pharmacology of volatile anesthetics.